Dr. Summer Baird, one of our senior residents, is going to be talking about stressed out ST segment depressions in AFib with RVR.
All right. Hey guys, thanks for coming. So just to start off, I have nothing to disclose, and I thought we'd start off with a little bit of a case study here, and this is something that we get all the time. So it's a hypothetical call day, and the pager goes off. ER is telling you about a patient, 52-year-old female, past medical history of type 2 diabetes, hypertension, paroxysmal AFib, and hyperlipidemia, and she's here for chest discomfort. It's her first episode of ever having this sensation. The troponin from your triage labs is 0.3. We get an EKG and we see that it's significant for AFib with RVR. And Dr. Jose, before we go any further, I want to say that the hypothetical TSH was hypothetically normal. The EKG is significant for ST segment depressions along the precordial lead, specifically V3 through V5, as well as, I believe, 2 and 3. So in this hypothetical situation, you give the patient your rate-controlling drug of choice, their heart rate's reduced, troponin trends down, and their symptoms improved. You're feeling pretty good about yourself. But we're still left with this clinical decision of what do we do about that ST segment depression? Do we nuke the patient? Do we go straight to the cath lab? Do we disregard it completely? So the presence of ST segment depressions in AFib with RVR is a fairly common phenomenon, and in some medical communities, the patients will be considered for catheterization as your next appropriate step. And the thought behind this is that your heart rate being elevated in the setting of AFib with RVR has challenged the heart similar to how exercise would challenge the heart. In return, the EKG demonstrates an inability to meet up with this demand. You see these ST segment depressions during this time of physiologic stress, which is thought to be not dissimilar from the EKG changes seen on a treadmill stress test. In this sense, AFib with RVR is seen as a sort of functional stress test, or you might see it referred to in the older literature as a positive stress test equivalent. So our myth for today that we're questioning is this accurate? Do ST segment depressions during AFib with RVR correlate with an underlying coronary artery disease? So in order to further look into this myth and kind of understanding the rationale behind it, we need to first consider the overall association between AFib of any type and cardiac ischemia. We know that CAD can lead to AFib. AFib is a complication of about 10% of all MIs, and in the appropriate clinical setting, a cardiac cath may be part of your initial AFib workup, usually after a nuclear stress scan. This is a very multifactorial relationship. There was actually a study that was done called Myocardial Infarction and Atrial Fibrillation, in which they gave sheep hearts MIs by occluding the left circumflex LAD and RCA each in turn. They found out that the mechanism that drives AFib from ischemia is related to both the direct trauma to the area as well as stretch effects and neurohumoral effects as well. I thought this paper was really interesting. I don't know that the sheep felt similarly. But we do see that the inverse of this statement is also true. While CAD can lead to AFib, AFib can lead to MI. We know that AFib in general does convey a greater risk for MI. This was demonstrated in the September 2017 journal article in the European Journal of Preventive Cardiology. They did a meta-analysis of 15 different cohort studies and found that there is a significant increase in MI with AFib patients, particularly in females stronger than men. This was associated with a relative risk of 1.54. It's also pretty important to remember in these patients, a lot of the discussion around AFib kind of tends to circle back to bleeds or strokes, but the actual highest cause of mortality in these patients is related to cardiac death. So great, we know that AFib and CAD are really tightly related, so great, call the cath lab, let's get this thing started. It also doesn't help that a lot of these patients that have AFib have a lot of the same comorbidities as MI, with particular age being one of them. It's also concerning that they tend to show up with a lot of similar presentations, including chest discomfort, a troponin bump. So viewing AFib under this lens with RVR as a sort of functional stress test seems to kind of logically, from a gut feeling, make sense. But we need to decide here if it's actually an accurate decision based on the evidence. So I think it's really important to remember in these settings that while a group of patients might be of increased risk for CAD and MI, it doesn't mean that each individual patient themselves has CAD or MI, similar to how you would not consider every diabetic patient to have CAD. So let's start with an article from the American College of Cardiology from September 2007. This is the value of myocardial perfusion single photon emission computed tomography and screening asymptomatic patients with AFib for coronary artery disease. It's a mouthful. But what was done here, it's a retrospective study that was conducted of 374 AFib patients that were asymptomatic for classic CAD symptoms. And for classic CAD symptoms here, we mean things like chest pain, dyspnea, also left bundle branch block, and with a known history of CAD or valvular disease. From here, they performed a nuclear study and they compared the mean stressed score to similar cross-matched patients of age and gender that were without AFib. They found no significant difference in the incidence of high-risk studies between the two groups, with roughly 14% of each group having an incidental finding of occult CAD. You can see here on this graph, the dark columns are associated with the atrial fibrillation group and the light columns are associated with the non-AFib group. It's important to note here that the low, intermediate, and high risks that they're referring to are the scores from the actual stress test, not in regards to their kind of risk factors. There was a separate clinical risk score that was calculated based on age, gender, and presence of diabetes, but they were not able to find a very strong association with the clinical risk score. So we'll take a look at a different study here now, and this is association of transient ST segment depression and AFib with RVR and ischemia and myocardial perfusion stress imaging. This was a study with a single institution over 7 years. They took patients that had documented AFib with RVR and had a nuclear stress test done on the same admission. It's important to note that this is a pretty small study. They had 412 patients initially enrolled, but then only 38 met selection criteria, and of that 38, only 11 of whom were actually found to have ST segment depressions and therefore were able to undergo comparative studying. They were able to perform a chi-square analysis and found no significant association between ST segment depression and AFib with RVR, as well as a nuclear stress test. There's one other significant limitation in this study, and they had quite a few exclusion criterias, also similarly to the past one, left bundle branch block, previous CAD, anginal symptoms, so we could potentially be excluding some patients that were slightly high risk from this study. So from here, we want to look a little bit further. This study was actually done in the Journal of Emergency Medicine in October of 2016. They were analyzing the predictive accuracy of ST segment depression and AFib RVR, and instead of using a nuclear stress as the last two studies examined, they actually went in deeper and performed a catheterization on these patients to try and find the association. 35 of the patients that they had analyzed had ST segment depressions on the initial EKG of at least 1 millimeter. After catheterization, they found that there was no association between the ST segment depression and the presence of obstructive CAD. One thing that's really interesting about this study was they actually did a stratification before and after analysis of the TIMI score and found no association either before or after. Kind of why this is relevant to us is that a lot of times these clinical decisions that we're making regarding whether to further stress a patient, whether to cath a patient, are based around these kind of TIMI score variables and how concerned we are at baseline for this patient to be having some kind of a critical cardiac event. So then we look at kind of the big whammy of a study. This one was done in November of 2007. It was a prospective study. We had 83 patients with relatively new AFib that had begun within the last 30 days. They were noticed to have ST segment changes on EKG on initial evaluation. All of these patients were hospitalized and converted back to normal sinus rhythm at some point during their hospitalization, at which point their ST segment changes had all resolved on their repeat EKG in normal sinus. They stressed them every which way. They stressed them with a treadmill stress test, with a myocardial perfusion scan, a dobutamine stressed echo, and then finally with a catheterization. And even after all of this really aggressive stressing, they found no significant association between the ST segment depression and occult CAD when compared to non-AFib. One thing that was kind of interesting about this study in general, though, was that they had a secondary kind of endpoint analysis that they were considering, which is the most appropriate confirmatory test. Let's say you have a patient and you're highly concerned that during this episode of AFib, maybe that this wasn't a cardiac crisis, but there could be something down the road, or at least we should be investigating further. This study actually found that a dobutamine stress echo might be considered the most sensitive confirmatory test with an 89% negative predictive value. Also interestingly, this test did find the highest prevalence of CAD in their quote-unquote low-risk population, with roughly 33% of the studied patients resulting positive. It is important to note, though, that this was comparable to their non-AFib group and that they had a much broader exclusion criteria than in previous studies. They were allowing for things like dyspnea, which they said could be attributed to just the AFib as well, which had been a factor that was excluded from a lot of the previous studies. So to sum it up, AFib is does appear to be correlated with a higher incidence of myocardial infarction overall. These are patients that we should be thoroughly considering whether or not they would merit from, a stress test or some other investigation for CAD. However, with that being said, ST segment depressions in the setting of AFib with RVR are a rate-related phenomenon. They are not associated with underlying CAD. So the decision to undergo cardiac catheterization or even stress imaging to confirm is really better based on clinical history, particularly the presence of anginal symptoms prior to hospitalization, as well as other risk factors. In general, if you were thinking about stressing the patient in another way or performing a catheterization, it's kind of easier to almost exclude this particular event of the ST segment depressions in that decision making, as the incidence of ST segment depressions does not appear to have any impact on the overall outcome. So with that in mind, as leading experts, Jimmy Buffett and Bob Marley once said, we're not going to stress. And there's my references.
All right. Thanks, that was great. I don't really have much to say. I didn't know that this was something that's commonly or frequently thought. So I don't have any other comment. The only question I personally have is, I forgot to ask you, did you find any data actually to support this?
In one of the studies, they did find that there was a slight association between kind of the depth of the ST segment depression and a greater incidence of CAD. And while the stress test criteria is typically 1 millimeter depression, they found that if it was greater than 2, there was maybe a questionable association with CAD. However, when it was adjusted for TIMI score, the association was no longer statistically significant.
Okay, great. Any other questions or comments? I was going to call on you, even if you didn't ask for the mic, I was going to call on you, Harris.
We have to strike.
So
if you think about it, when you do a dobutamine stress test, you're driving up the heart rate to see if you can create regional wall motion abnormality. If you do it when the patient is in atrial fib with rapid rate, you don't have to do the dobutamine stress test. He's doing it or she's doing it for you because the heart rate is up, and if the ST segments are ischemic, you should be able to see a regional wall motion abnormality on the echo. So that'll just, truncate the whole workup. And that's what we do. But any kind of supraventricular arrhythmia makes ST segment depression much less specific for ischemia, especially in the absence of angina.
okay, thanks. Anybody else? Any other comments? Okay, I'm seeing none. So this is what we're going to be voting on. ST segment depression during episodes of AFib with RVR can be used as a functional stress test. How many people think that this is true, that it is a functional stress test? How many think it's plausible? How many think that this is busted, this is a myth? All right, great.